It is now my pleasure to introduce our COVID-19 panelists. Professor Jerry McElvaney is the chairman of the Department of Medicine and professor of medicine in the Royal College of Surgeons in Dublin, Ireland, and the lead panelist of this session. He is joined by Dr. Robert Sandhaus, clinical director of the Alpha One Foundation. Professor David Parr is a practicing consultant respiratory physician at the University Hospitals Coventry and Warwickshire and is honorary professor of respiratory medicine at Warwick Medical School. Professor Pavel Strnad is a professor and leading physician at the University Hospital Aachen, Germany. Professor Joanna Chorostowska is a professor of medicine, head of the Department of Genetics and Clinical Immunology, and a consultant in respiratory medicine at the National Institutes of Tuberculosis and Lung Diseases in Warsaw, Poland. Dr. Mariano Fernandez Acquier, who is the associate director of the Strnad Hospital, a public respiratory disease center in Buenos Aires, Argentina. He specializes in pulmonary and internal medicine. The panel will now have a roundtable discussion focused on COVID-19. The floor is now yours, Professor McElvaney.
Welcome all the fellow members of the roundtable. And it's a very interesting area, COVID-19, still topical, unfortunately. And we've all got different experiences to share and discuss. So I'll start by asking Sandy to tell us something about his work, particularly with the AlphaNet group that he's been leading, and how COVID-19 has impacted upon those people in the US. Sandy.
Happy to present some of the data that we've been able to collect about the individuals in our community who've been affected by COVID-19. I'm going to give just a really brief summary of much more data that we've collected in the AlphaNet program, which follows over 7,500 individuals with alpha-1 antitrypsin deficiency, heavily weighted towards patients with lung disease who are on augmentation therapy. And we ask them every month questions about their health condition. And beginning in the first week of April of 2020, we started asking questions about COVID in our monthly calls. And so here will be a brief summary. Some of you may have seen the results that we've generated with from April through the end of June, but we've now added an additional 2 months of data. Here's the number of subscribers, unique subscribers, who reported that they were diagnosed with COVID-19. You can see that there are, in our data that I'll be presenting today, there are over 7,500 unique subscribers who answered these results. You can see that when we just looked at the data through June, there was a nice trail off of the incidence of COVID infections, which picked up again in the subsequent 2 months that we've added here. When we look at the percentage of our total population who've been diagnosed, it's about 10% currently through the end of August, which is about half of the incidence in the general adult population of the US. So our participants are keeping themselves safe from COVID, presumably by following all of the recommendations for self-protection and community protection that have been out there. When we look at those who did get diagnosed with COVID, you can see in this pie chart that about 68% of them were treated at home and had a mild enough case that hospital admission was not required. But a total of about 32% of our population was treated in the hospital or the hospital in the ICU. And this is, in the general population of the US, about 16% of those diagnosed with COVID required hospitalization or ICU stay. So this basically suggests that patients who do get sick with COVID, who have alpha-1 antitrypsin deficiency, lung disease primarily, are more likely to wind up admitted to the hospital. I will say that those who receive augmentation therapy to treat their lung disease in our group often had to stop their augmentation therapy when they were admitted to the hospital because it's difficult to arrange for such a therapy to be transferred to a hospital pharmacy situation. And that may contribute to the severity of disease if alpha-1 is in fact protective in some ways of lung damage due to COVID, as it is for other lung infections. We looked at COVID vaccinations in May of 2021 with a single question, asking people if they've had a first dose or a final dose, and at the time that we asked in May. And you can see that, and asked them when they got their last dose. And you can see there's a spectrum that has trailed off by May and presumably picked up with more vaccination mandates in the United States over the recent months. And we'll have that data coming in the future. So in summary, first of all, regarding the COVID vaccine, it's clearly the most effective way to prevent serious infection and death in COVID. Our one vaccine has been received full U.S. FDA approval for people 16 years of age and older, and then there are emergency use authorizations for 2 additional vaccines that you can see here. Our recommendation to patients, of course, is to get vaccinated because the benefits greatly outweigh the risks of adverse reactions. As we tell our patients who question, vaccines don't cause sterility, don't cause mind control, don't change your DNA, et cetera, et cetera. And one of the most distressing new events in our community is that there are people who believe that augmentation therapy immunizes people against their will or provides unwanted antibodies against the SARS-CoV-2 virus. Neither of which appears to be true. Summary, alphas have done a good job of protecting themselves from COVID in this study compared with the general population. However, when they do get COVID, they're more likely to wind up in the hospital or ICU. We do not have systematic data regarding deaths due to COVID in the alpha-1 community because the alpha-1 community is very concerned about privacy and confidentiality, and don't provide they do provide, but don't provide things like social security numbers that would allow us to query the National Death Index database. Please protect yourselves from COVID. Make sure your patients get protected from COVID. Get vaccinated yourselves and your patients get vaccinated. Get boosters when you qualify. And above all, I'd like to thank the AlphaNet coordinators who are all Alpha-1 patients themselves who collect these data, and to all the AlphaNet subscribers who make this kind of analysis possible. So that's my summary of what we've learned at AlphaNet.
Yeah, thank you very much, Sandy. And I think it sort of jives quite well with what we're finding here in Ireland as well. So David Parr's on the call. David, would you like to briefly discuss your work with ARCO in this area?
Yeah, thanks very much, Jerry. And we took a slightly different approach to the approach that Sandy's just described. The EARCO is an ERS supported initiative to generate registry data across Europe. And so this struck me as an obvious platform to obtain information early on in the pandemic. So it was proposed that we asked all EARCO members to provide information that they had on COVID outcomes and experience in their own country into the database for analysis, in the expectation that we would come across cases that would allow us fairly quickly to get some idea of what the risks of COVID posed to patients with alpha-1 antitrypsin deficiency. The design of the study was to identify patients with severe deficiency, so patients with an SZ or a ZZ phenotype or an equivalent level with a rare variant. And frustratingly, we didn't have any data for a long time, which of course is good, because the lack of data indicated that patients with alpha-1 deficiency were very effectively shielding themselves from getting infected. So there was a significant delay in us being able to get any data that was of any use. But by June of this year, about a year after we started collecting data, there was enough data to submit an abstract to the ERS. And I don't know whether or not Randall's got that to show, but essentially we had about 56 patients with a mortality rate of around 5%. The likelihood was that your FEV1 didn't change appreciably over the course of the time that we had been collecting data. So we only managed to get spirometric data on about half of the patients, but in those that we did collect data from, with a baseline measure and a post-COVID measure, there wasn't an appreciable difference. But of course, there's a significant selection bias there. So I think drawing any firm conclusions from that is potentially unreliable. And I think the other thing that is worth pointing out, that we are only looking at spirometry, which is just one dimension of what is likely to be quite a complex pathological process, and therefore a lack of things like gas transfer measures means that we will be missing potential changes as a consequence of COVID. But I would say that this is quite reassuring, in that we had patients with very severe disease in terms of their lung impairment from their emphysema, even with patients who were on lung transplant waiting lists, who contracted COVID-19 and didn't just survive, but they didn't have any appreciable change in their health status after recovery from COVID. That's the preliminary data. We have since obtained further data, and we are in the process of publishing the outcomes of that in a group of patients with fairly comprehensive data in about 100 odd patients. So I'm hoping that will provide further insight into the effects of COVID in alpha-1. And I would say that it doesn't look as if alpha-1 constitutes anywhere near as much of a risk as was initially feared. And I wouldn't go as far as to say that it constitutes a significant risk over and above the general population and an increased risk of hospitalization or ITU. But the way that we've collected data is very different from the AlphaNet data. And I think there's no ground truth here. It's something which there's a degree of uncertainty, but we have to make the best of the data that we've got available. And I hope that this does provide some guidance and reassurance, not just to the physician community, but the patient community. So thank you.
Thank you very much, David. Any questions for David on that?
So we have some questions coming in. I just saw a hand get raised though. Joanna, you're going to add to it.
I have a question, let's say very practical, very clinical question. My reasoning is that we, as a alpha community, that means patients and clinicians, were so cautious about COVID-19, that observational studies for the moment might not really show us the whole spectrum of the, let's say, the real life risks and the real risks linked to COVID-19. And I do believe that if we decide on the observational studies, we probably need to make sure to do the follow-up and the continuation of those observations. Otherwise, the data would be as they are. At least what I see in my group of patients is definitely decrease in the number of exacerbations in the previous year. This is what I observed, and I don't believe this. That just reflects the social distancing, in my opinion. Thank you.
Yeah, I would agree. We have seen decreased exacerbations but I think that's because they're keeping away from everyone else and wearing masks and hand hygiene, etc. And my own, our own data and my own feeling is that you may not get more infections with alpha-1, but you probably get more severe infections. So that's my take of it. Pavel, you got your hand up there?
Yeah, so I just wanted to comment about the issue that Joanna raised. So there is this large population-based biobank called UK Biobank, which has AAT genotyping, and most of the patients, especially the ones with mild genotypes, are not even aware that they are MZs. So from this biobank, it's at least very clear that the MZs are basically not having any additional risks. And it seems also that the SZs don't seem to have an additional risk. The numbers for ZZs are too small to make really major conclusions, but basically the biobank-based data where the people are not even aware of the fact that they are alphas, especially for the mild ones, would also suggest that there is no major predisposition.
Joanna, what are your thoughts on the situation in Poland and your general experiences of COVID-19?
Well, I am really happy to say that my patients were not affected by COVID-19 in terms of severe situations, except of very few patients. All of them either were let's say safe from the infection or had quite mild infection with SARS-CoV-2 virus. So I, in terms of the general well-being of my patients, I could risk saying that they actually did pretty well during the pandemic, except of course, the emotional, the way the whole situation affected them in terms of quality of life and emotional well-being. This is of course a different issue.
Yeah, of course. And Mariano, in Argentina, any particular insights from Argentina?
Yes, as Joanna says, we can also see a decreased number of exacerbation, and we think that the personal protective equipment that use their patient is one point to take in consideration. And in Argentina, we also have the possibility to switch outpatient clinic to home therapy in the vast majority of individuals. So first of all, we discussed this possibility with the patient, and after that, if the patient agreed to this, a high level of adherence was certainly guaranteed, and they are really very happy with the possibility of the home therapy, and was this a great and important thing in our country. Very
good. So I might just share some slides of our own, if that's okay, Adriana, if you can put up my slides. So just to give some background, when the COVID-19 problem hit us, our biggest fear was for two patient populations, for cystic fibrosis and alpha-1 antitrypsin deficiency, which we look after. And we were very worried that both these groups would be really compromised if they got a severe infection. We didn't think necessarily they're more prone to infection, but if they were to get an infection, we'd be in trouble. Now, what we found actually in our CF population, which is quite interesting, in the CF group, we found that there was no increased COVID-19 infections, but one person got an extraordinarily severe one, and a few other people didn't get it as bad. But to talk about our alpha-1 population, our fear here revolved around a number of issues. Number one, the cytokines. The classic cytokine associated with COVID is interleukin-6. And we know that interleukin-6 is a major role in initiating and producing alpha-1 from the liver. So we were worried again that in severe cytokainemia secondary to COVID-19, that you would see an alpha-1 response. And the question was how good that response was. And I just go back a slide there, Joanna, or sorry, Adriana, sorry. So this is an interesting slide from a paper by Ollie in the Blue Journal. And what we looked at was how good was IL-6 at getting alpha-1 out of the liver in people with this infection? Because we knew their alpha-1 levels were significantly higher than normal. And what we found was the IL-6 alpha-1 ratio was dramatically high in those in the intensive care unit. So in other words, when these people were getting severe COVID infections and at high IL-6 levels, the natural response, the protective response, is to produce alpha-1. And we found that the people who did worse were unable to produce as much alpha-1 as those who were stable or those who were in the ICU with community-acquired pneumonias. And the other thing we noticed that in the people who got, and these are M individuals, I should mention, these are MM individuals. And we also noticed that in people who got COVID infection, when we look at their alpha-1 using isoelectric focusing and immunoblotting, we noticed a lot of M0, M1 bands. And that was very interesting because interleukin-6 not only upregulates alpha-1, but upregulates the enzyme that sialylates alpha-1 and makes it very good as an anti-inflammatory. So for us, alpha-1 was very key in response to COVID in MM individuals. Next slide, please. And we looked at this a bit further, and we found that if you looked at good outcome versus bad outcome in COVID, that a high IL-6 alpha-1 ratio predicted a bad outcome, whereas a lower one was associated with a better outcome. And we didn't see the same in community-acquired pneumonia. So that made us think that, first of all, that alpha-1 is important in COVID infection. It led us to do a clinical trial of alpha-1 in COVID infection, which hopefully will have preliminary data within the next few days. It inspired Robert Baz to do a similar study with some intimation of some efficacy, but it was a very small study. And with that in background, we were worried that our alpha-1 patients who might not be able to mount this really good anti-inflammatory response, would they have a more severe problem if they got COVID infection. And so we looked at our alpha-1 population. Next slide, please. And it was quite interesting. This is our data. We rang up a large number of individuals. We had a reasonably good response rate. And we found that about 11% of our alpha-1 population got COVID. And then of those who got COVID, about 50% of those who got COVID attended hospital. And then one was admitted to the ICU and one unfortunately passed away. So slightly higher than the general population with regards ICU and hospitalizations, a bit similar to what Sandy has shown in his data. But we were very aware that we had a very good vaccination program in Ireland and that a lot of our people were getting vaccinated very early. Next slide, please. So we looked at our vaccination process and we were very aware that there was a lot of, I suppose, scares in the population about vaccination. Next slide, please, Adrian. So we were wondering then, what was the attitudes to vaccination in our alpha-1 group compared to a COPD group, compared to a healthy control group? And that's what we're interested in. And specifically, we're also interested in, I suppose, the possibility that alphas would get more side effects. And so here's the data we have from the side effects in our non-lung disease population, MM COPDs and ZZ alpha-1s with COPD. And we found that there was quite a lot of side effects, but there was no difference between alphas and MM COPDs in the number or type of infection. It's just that there was more infections, more side effects identified than you'd garner from reading the literature. And the reason for that is we are calling these people on a regular basis and following them up very closely. So there were quite a lot of side effects actually, but there weren't any more in the alpha-1 population versus the normal population. And that's a very useful thing for us. So the MM population did not have any more side effects than the ZZ population that we were studying. This is an MM COPD population as well. So that was intriguing and useful for us to have that information. And then can you move on there a bit, Adriana, if you can? Now, so our preliminary data shows that the people at highest risk for adverse events with regards to vaccination were young females. The systemic adverse events, multiple systemic adverse events, and was seen across all the groups. So in the healthy controls, the people, MM COPDers, and ZZ individuals as well. So what we were gratified to see was that clinically, there was no increased adverse events in our alpha-1 population with regards to vaccination. Now, the interesting thing was we then wanted to see what made people get vaccination. Yeah, the motivation for accepting vaccines. And this is in our healthy control group here. So they have no lung disease, they're less than 50 years of age. And our government will be making a big deal about trying to get people to get vaccinated. And the main reason why the younger group wanted to get vaccinated was they wanted to socialize. And that's interesting. The government was under the false illusion that the younger people wanted to avoid passing on infection. But the reason they wanted to get vaccinated was they wanted to socialize. And part of the reason was if you're double vaccinated in Ireland, you get access to various places that you wouldn't get otherwise. So that was that group. Next group, please. Next slide. If we then look at our non-lung disease greater than 50, as people get a bit older, they start worrying about getting severe illnesses or death. And that's what we saw in the older population. So the younger people, they wanted to get vaccinated because they wanted to socialize. As you get a bit older, you're afraid of severe disease or death. Your next slide, please. And we look at our COPD population over 50, a significant number were worried about severe illness or death. That's partly due to the, I suppose, I wouldn't say hysteria, but the very real fear that people had at the start of the pandemic that this was a really severe and deadly virus. So again, in this group, relatively few got vaccinated because they wanted to get socialization, but there were a lot of them getting vaccinated because they're afraid of death. And we look at our alpha-1 population, next slide, please. Less than 50, again, it's not too dissimilar to the non-lung disease group. A lot of them wanted to socialize, so less than 50, they were less afraid of getting severe illness or death in the alphas. But if you look at the alphas over 50, next slide, please. A big number got vaccinated because they were terrified of getting bad consequence of a severe infection. So this data suggested to us was as follows, I suppose, that in our alpha-1 population who got vaccinated, there was no increased risk of side effects compared to the general population, at least symptomatically. But when we look at the reasons for vaccination, the alpha population over 50 were very quick to get vaccinated if given an offer because they were worried, rightly so I think, of being getting a severe illness or death from a vaccination. So I think in a way it tells us a lot about how government agencies should proposition vaccinations to a general population. For some groups, you aim at socialization. For other groups, you aim at their health. And that's something we've learned from this. But to go back to the initial question, I think people with alpha-1 who get severe infections or get a COVID infections, they will try to mount an anti-inflammatory response. And we got one patient who got a severe pneumonia, COVID pneumonia, and he was a ZZ whose alpha-1 levels managed to reach MZ levels. But to put this in context, our MM individuals who got severe COVID infections, they were getting alpha-1 levels 2 to 3 times above normal. And that suggests an attempt at an anti-inflammatory response. And the question for me is twofold. If a ZZ individual gets a severe infection, they'll do their best to get the alpha-1 out, but they're not getting enough anti-inflammatory, anti-protease protection into their systemic circulation or into their lungs. And secondly, in their attempts to make more alpha-1, they theoretically can make their liver more inflamed. And that's something we need to look at, I think. Thanks very much. Any questions about that or any discussion about that?
Jerry, can I make a comment? Mark?
Yeah, sure.
Yeah, so I was pleased to see that the Irish are just as selfish as the Americans are in that spreading the disease was a minor component.
Absolutely.
I think it says something about our societies
Yeah.
that's such a low consideration.
Yeah. Well, and you're right. And there's a lot of Irish Americans as well, I suppose. So that might explain it. But I think it's an interesting thing because when our government mounted a campaign for vaccination, their big thing was that don't kill your granny, basically. And the reality of it was people were more worried about going out and socializing. And there's an interesting point that I think you have to target your message to different age groups and to different populations. And by doing that, you'll be more effective, I think. Because people, one of the things that struck us, and it's an important point, of those people who got side effects after vaccination, we found that if you're very upfront with people beforehand, if you tell them what the potential side effects are, what the way, how we'll treat them or how we'll deal with them is, if you can tell that to people up front, you'll almost certainly get a more understanding if an adverse event occurs, and also a willingness to get the second vaccination, or in some cases the booster vaccination. And that's an important point, because a lot of people will get a one vaccination, they get a bad result from that, they may be less likely to go for the second one. But what we found was that we're very open with our patient populations, both COPD and alpha-1 patient population. If we're open with them, try to predict a priori what the side effects might be, and be open to communication in the event of side effects, we found that we had a very good result with regards to second vaccination.
Thank you. Dr. Techman, would you like to pose your question to the panelists? I see it in the chat. If we can unmute Dr. Techman, that would be great.
Yeah, it wasn't really a question. I was just commenting that
Yes.
as you know, as Jerry showed very effectively, and as we know, alpha-1's an acute phase reactant, and we know in the liver, anecdotally, that sometimes individuals' livers get a lot worse if they have an episode of inflammation, be that appendicitis, a gallbladder attack, something else. And to see, Jerry showed the upregulation of alpha antitrypsin during COVID. And my suggestion was we ought to be following those patients up with regard to their liver, because a huge increase in Z protein synthesis in the liver will lead to a huge increase in Z protein accumulation in the liver, which is a thing that kills your liver. So let's follow up all the lung outcomes in Sandy's patients and see what happens to their livers over the next few months.
I absolutely agree with that, Jeff. I think that's an absolute certainty that whatever we see in the lung, the potential for liver inflammation is quite significant, I would think.